In this presentation, we will explain the surgical treatment for prostate cancer that you can trust with Urosalud. We will discuss the procedure, the benefits, and what you can expect during your recovery. Our goal is to provide you with clear and useful information so that you feel confident at every step of the process. Your health is our priority, and we are here to support you. We will learn about your disease from 3 perspectives. First, we will talk about the anatomy of the prostate. Then, we will explain what the functions of the prostate are. And finally, we will discuss prostate cancer. In this drawing, you can see what would be the lower urinary tract, the bladder, the urethra, and the prostate which surrounds the urethra. The image also depicts prostate cancer as a black spot. If we enlarge the image on the right, you can see how the bladder functions as a hydraulic pump that ends in the urethra. That urethra is surrounded by the prostate, which somewhat resembles a tangerine or an orange, as it has a rind, segments, and a capsule. At the junction between the segment and the left rind, another black lesion is represented, corresponding to a small prostate cancer. What is the purpose of the prostate? The prostate plays a crucial role in the production of seminal fluid, which is an essential component of semen. This fluid not only helps sperm swim and move, but also provides them with the necessary nutrition for their survival and mobility. What diseases does the prostate suffer from? Once we have had children, the prostate can become a frequent source of problems, as it can develop 3 main diseases: benign prostatic hyperplasia, prostatitis, and prostate cancer. Let's understand what benign prostatic hyperplasia is. Surely you know many patients who suffer from benign prostatic hyperplasia. They are patients who have urgency to go to the bathroom, a feeling of incomplete emptying, or difficulties urinating. In the drawing on the right, the prostate enlarges and exerts external pressure on the urinary duct, obviously making urination difficult. Another disease that frequently affects the prostate is prostatitis. In this case, a bacterium enters through the urinary tract and reaches the prostate, where it proliferates and causes an infectious process that can present with significant fever. This is what we know as acute prostatitis, and we come to the dreaded prostate cancer. In this slide, you can see the bladder, the urinary duct, and that prostate that looks like a tangerine, but has 2 cancers, a small one on the right side and another larger one on the left side, which is starting to break through the prostate capsule. There is no need to feel bad about having prostate cancer. As I tell my patients, prostate cancer is the most common cancer in men. Patients who do not have prostate cancer are often those who die earlier from other causes, such as accidents, heart attacks, or other tumors. But if we want to live a long life, if we want to live many years, it is very likely that in the future we may develop prostate cancer. At the same time, it is an important disease. In the graph on the right, you can see that prostate cancer is the 5th leading cause of cancer death. 1 in 8 women will suffer from breast cancer. Similarly, 1 in 9 men will suffer from prostate cancer. It is necessary to remember that estrogens are involved in breast cancer. In the case of men, testosterone is involved in prostate cancer. Interestingly, what does the breast produce? Breast milk. And interestingly, what does the prostate produce? A fluid similar to breast milk, which is semen, and allows sperm to swim, move, and nourish themselves. Both are glandular organs that can develop very similar tumors. In reality, breast cancer and prostate cancer are diseases with certain parallels. However, everyone knows the pink ribbon, which aims to raise awareness about the importance of breast cancer, and very few people know the blue ribbon, which aims to raise awareness about the importance of prostate cancer. And this time, the blame is not on the political class. This time, probably, the fault lies with the man himself, whose shyness prevents us from adequately raising awareness among the population about this scourge that is prostate cancer. When prostate cancer is diagnosed, it is very important to know what stage the disease is in. The first question we must ask ourselves is, have we diagnosed it in time? That is the disease organ confined? Is it localized only within the prostate itself? Or, on the contrary, have we arrived a little late? In the central drawing, you can see how prostate cancer begins to break through the prostatic capsule. Finally, in some scenarios, unfortunately, we may have arrived late and prostate cancer may have spread metastases outside of the organ itself. It is also important for patients to know where prostate cancer can metastasize. Obviously, if a patient has a very low-grade prostate cancer, it is usual that there are no metastases. But if a patient has aggressive prostate cancer, regardless of whether we have diagnosed it in time or not, there may be some risk, sometimes lower and sometimes higher, of metastases existing. Therefore, it is necessary to know where prostate cancer usually metastasizes. Prostate cancer can spread metastases to the lymph nodes. as you can see in this image. It can also produce metastasis in the bones. Unfortunately, in later stages, prostate cancer can metastasize to other organs, such as the lung or liver. When we diagnose a patient with prostate cancer, the important thing is to establish a trusting relationship between the doctor and the patient, because we will have to share important decisions. There are three main objectives when diagnosing prostate cancer. The first and most obvious is to cure the patient. This will be the goal in most cases. The second objective may be to explain to the patient that they can live with their prostate cancer. This occurs in patients with very little cancer and with very non-aggressive tumors. And finally, in those patients who already have metastases and in whom the disease cannot be cured, the objective will be different: to manage prostate cancer as a chronic condition. Therefore, we repeat, three objectives. The first, to cure. The second, to live with cancer when it is a very small and non-aggressive tumor. And the third, to chronify the disease in those patients in whom the diagnosis has been made late and metastases already exist. It is also important to understand how the patient is from an emotional standpoint. A very nervous patient who we diagnose with cancer and collapses to the ground out of distress or fear is not the same as a calmer patient. Why is this important? Because obviously, a very nervous patient is unlikely to be able to cope with prostate cancer or monitor it calmly. On the other hand, in a calm patient, active surveillance of prostate cancer can be an excellent option, as long as the characteristics of the tumor allow it. Afterward, the information provided by the biopsy is very important. If you read the biopsy report, you will see that having a Gleason 6 prostate cancer, which is a very non-aggressive cancer, and which we represent here as a kitten, is not the same as having a Gleason 8, 9, or 10 prostate cancer, which corresponds to a very aggressive cancer. Between both extremes, there is an intermediate category, which is Gleason 7, a cancer of intermediate aggressiveness. Therefore, we repeat: Gleason 6, non-aggressive; Gleason 8, 9, or 10, very aggressive; Gleason 7, intermediate aggressiveness. We also have to keep in mind the amount of cancer present in the prostate. We know this thanks to the MRI and the number of cylinders or biopsy samples that have come back positive. We may have a small amount of cancer confined within the prostate, or we may have cancer that begins to extend beyond the prostate, breaking through the prostatic capsule. In that case, we would be talking about locally advanced cancer. In this table, you can see 6 boxes. In the top left box, there would be patients suffering from a very low grade and low quantity cancer. On the contrary, in the bottom right box, there would be patients diagnosed with a high-grade cancer that begins to break the prostatic capsule and is also very aggressive. Here we would have the example of a very low aggressive prostate cancer with a small amount of tumor. In this scenario, active cancer surveillance may be a very good option for many patients. Also, in some selected cases, other alternatives such as focal therapy or surgery could be considered. For example, let's think about a more anxious patient. They have a little cancer. The cancer is not very aggressive, and we have diagnosed it in time, but the patient tells us, "Doctor, I don't want to live with cancer. I don't want to take the risk of the cancer progressing while I monitor it. Even if you tell me that active surveillance is reliable, I don't want to live with cancer inside my body." In that case, obviously, a reasonable option may be to undergo surgery. Here we provide another example: a medium-grade prostate cancer diagnosed in time and with a small amount of disease. In this case, surgery seems to be the best option. Living with a medium aggression cancer does not seem in principle to be the most appropriate, except in rare occasions that we must evaluate individually between the doctor, the patient, and their family. In this slide, we represent the different alternatives that exist to manage or treat prostate cancer. As you remember, very low aggressive prostate cancers and those of very small quantity can be monitored. In these cases, the patient can return to their routine the day after the biopsy and live with cancer in a controlled manner, something we will explain in more detail in another presentation. In a few patients, when there is an exquisite correlation between the MRI and the biopsy results, and the cancer is solely and exclusively where the MRI indicates it should be, only the tumor focus can be treated and not the entire prostate. This is what we know as focal treatment. Some patients with low or intermediate aggressiveness tumors, organ confined and of small quantity, can also be treated with radiotherapy or brachytherapy. And finally, in many cases, and especially in those of intermediate or high aggressiveness, surgery is an excellent option for disease control. In this slide, you see that the pyramid is inverted. Why? Because as you can see, the more potent an option is for controlling the disease, the more aggressive it can be, and therefore the more toxicity or potential complications it may associate. So it is fair to recognize that if you choose to monitor cancer, you will not suffer any complications arising from treatment because we are not applying active treatment. Focal treatment also has very low toxicity as long as it is well indicated. We know from the MRI where the cancer is, we only treat that area, and the rest of the prostate is hardly affected. Brachytherapy also tends to have low toxicity. It is true that when complications arise, managing them can be tremendously difficult. And finally, surgery. By removing the prostate, as we will see later, we jeopardize two very important functions: urinary continence and the patient's sexual potency. The question is, how can we minimize the toxicity associated with surgery? I repeat, how can we minimize the toxicity associated with surgery? By using the best technology in expert hands. And this is obvious, regardless of the profession you have or have had. An expert with the best available technology will do it better than someone with little experience or with more limited technology. Therefore, if we want to minimize the risk of urinary incontinence and erectile dysfunction as much as possible, we must use robotic surgery and place our trust in an expert surgeon. Many famous people have undergone surgery for prostate cancer, many of them through Da Vinci robotic surgery. Here you can see some well-known examples. Recently, it seems the King of England has also suffered from a significant prostate issue. Robert De Niro has also suffered from prostate cancer. And among all of them, one of the few who has done a true job of social awareness is the Hollywood actor you can see in the center line, to the right. Why does prostate cancer surgery cause us so much stress? As we have mentioned before, due to the risk of urinary incontinence and erectile dysfunction. In the left graph, you have a three-dimensional prostate. It's that small white chestnut. Inside that white chestnut, there is a black lesion, which represents prostate cancer. As you can see, above is the bladder, and below that white gland, there is a muscular clamp, which is the urinary sphincter. The sphincter is the organ that allows us to jump rope, go downstairs, laugh, or stand up without leaking urine. If that muscle is injured during surgery, the patient may experience urinary incontinence. In the drawing on the right, we see again the bladder above and the prostate, in this case represented in brown, with a black lesion corresponding to cancer. Also, notice those yellow nerves that wrap around the prostate. The nerves are responsible for the erection. If we damage those nerves when removing the prostate, the patient may suffer from erectile dysfunction or impotence after the surgery. I insist, we minimize those risks with a lot of strategy using the best technology, in this case, robotic surgery, but above all, putting the surgery in the hands of an expert surgeon. How is a radical prostatectomy performed? Here is a two-dimensional drawing. Above, we see that bag, which is the bladder that collects urine. In the middle is the prostate, with its black lesion, representing prostate cancer. And notice that the prostate continues with the urinary duct. On the sides are drawn the erection nerves, and right at the tip of the prostate is that muscle clamp, which is the urinary sphincter. The surgery consists of removing the prostate and the seminal vesicles. I repeat, removing the prostate and the seminal vesicles, but without damaging the continence clamp, and, as long as it is oncologically safe, without damaging the erection nerves. After that, the bladder must be carefully sewn to the urinary duct, respecting that muscle that allows continence and those nerves that allow erection. The goal is to cure the cancer while minimizing the risk of urinary incontinence and erectile dysfunction. Radical prostatectomy has more than 100 years of history. It became definitively popular in the mid-1980s in the United States. In Europe, laparoscopic surgery developed strongly, while in the United States, since the year 2000, robotic surgery began to spread. Today, robotic surgery has become a fundamental tool in the surgical treatment of prostate cancer, among other reasons because it allows for more precise surgery, more comfortable for the surgeon, and potentially more careful with important anatomical structures. In this slide, you have a comparison between conventional laparoscopic surgery, performed manually, and robotic surgery. There you can see a surgeon leaning on the robot's console, navigating during the surgery, as if using a surgical GPS throughout the entire procedure. Why is robotic surgery better than conventional laparoscopic surgery? Why is it at least slightly better? There is an undeniable fact that proves it. These are some of the great laparoscopic surgeons. Surgeons who, for me, invented, developed, and took handmade laparoscopic surgery to the highest level. What happens to them when you introduce a robot into their lives? Well, the same thing that happens when you give a taxi driver a Mercedes. They don't want to go back to the Dacia. They don't want to return to a more rudimentary technology when they have experienced a superior technology. No one wants to talk about conventional laparoscopy again when they have a robot available at home. Why? Because robotic surgery offers very relevant advantages in precision, ergonomics, and surgical control.
Lo que hemos hecho es una pequeña comparación de los instrumentos laparoscópicos, instrumentos rígidos que solo podemos torsionarlos en este sentido y abrir y cerrar, contra los instrumentos robotizados que tienen hasta 8 grados de libertad. Además, la estabilidad de los mismos retira y mejora el temblor esencial. Son instrumentos muy sofisticados que nos permiten sin duda alguna operar con mayor precisión. Esta es nuestra consola donde nosotros nos situamos mirando en esta lente binocular, y todo lo que nosotros hacemos en este joystick queda perfectamente reproducido dentro de la cavidad del paciente. Esta es la parte más importante del robot, el robot Vinci, que como veis tiene 4 brazos articulados que permiten todos los movimientos sin que haya colisión. La cámara siempre está en el centro, en este caso una óptica de cero que nos permite ver en 3 dimensiones con muchos aumentos y con una cámara tremendamente estable, que la calidad de la imagen sea significativamente mejor. Trabajamos en Full HD, 3 dimensiones, y aquí a la derecha y a la izquierda irá lo que supone nuestra mano derecha y nuestra mano izquierda del cirujano. Generalmente utilizamos la mano derecha para cortar y la mano izquierda para coger y coagular.
In summary, the robot provides the surgeon's hand with many degrees of freedom and consequently allows for more accurate and precise surgeries. This greater maneuverability gives us greater precision. Additionally, the robot eliminates the essential tremor of the surgeon's hand. The surgeon works comfortably at the console, and above all, the camera is stable. There is no image tremor, so the surgical vision is magnificent. But more important than the Da Vinci robot is the surgeon. Here you have a curve called the learning curve. On the vertical axis, we have the performance. On the horizontal axis, we have the attempts or the number of procedures performed. Regardless of the profession you practice or have practiced, you will understand perfectly that maximum performance is achieved after a sufficient number of attempts. Well, the same happens in surgery. This is called the learning curve, and it has been studied mathematically. Notice, for example, in open surgery, the learning curve saturates at approximately 250 procedures. That is to say, if in the 90s you wanted to have a good open surgeon, that surgeon should have performed more than 250 open procedures to be considered from the perspective of the learning curve, an expert surgeon. Subsequently, American groups demonstrated that even above 1,000 procedures, the results could continue to improve, with safer and higher quality surgeries. In the field of laparoscopic surgery, the learning curve saturates after approximately 500 procedures. That is, if you are going to have laparoscopic surgery, ask your surgeon how many patients they have operated on. It is important that they have performed more than 500 procedures to be considered an expert surgeon and to offer you surgery with the highest possible guarantees. In robotic surgery, however, the learning curve saturates at around 300 procedures. What does this mean? As the robot brand itself, Intuitive, states, it is a more intuitive surgery and easier to learn than conventional laparoscopy. But still, if you are offered robotic surgery, you should know that yes, it is probably the best technology, but only when it is in the hands of the most expert. As our motto says, the best technology in the most expert hands. Do not hesitate to ask your urologist how many robotic surgeries they perform per week or how many patients they have operated on. The surgeon's experience matters a lot. Thank you very much for your attention. We hope to have shed some light if you are suffering from prostate cancer and are considering what might be the best treatment for your case.